Good evening. Okay, so what I'm going to talk about a little bit brief is not something unique, any big research. I'm just talking about deceased donor transplantation, which I think in the last year, SGPGI has started picking it up, and this is the SOTO for the deceased donor transplantation. But what I'm trying to talk about is what goes behind the deceased donor transplantation. I'm not going to talk about how to increase it, what is the requirement, everybody knows it. But certain points which may be to somebody's liking or may not be to someone's liking as to what is going on as far as deceased donor transplantation is concerned. So this is our PGI's figure from 2010 onwards, that how many are the deceased donor. As usual, pretty stable number, 60 to 78, around 3 4 years, and then there was a drop in number again at 26. And this was the time, I think, when Professor Dhiman, Professor Yogesh Chawla took over to increase, and how to increase, he knows the best, how to hold the meeting, whether to get it on the license, etc. But I'm not going to talk about that. I'm going to talk about this part, why it is not consistent, why it is not stable, why it keeps on dropping, etc. Now, behind the wheel, I think I like this Sri Aurobindo's quote, that what we call the knowledge is nothing but whatever we have accepted by reading or etc. And the real wisdom is to look behind that wheel and then try to find out as to what is going on behind that thing which is there. Now, what are we trying to look behind the wheel? Well, somewhat not so positive things. Uh, the grim reality, that is, whatever we are doing, the number of transplants, it's mainly for the media, it's mainly for the number game, rather than what is required. That's the point one. And secondly, is the live transplantation and the disease transplantation complementary to each other, or is one coming at the cost of other? Is there an analysis available where that the total number of a transplantation in the country as a whole is increasing, or is it cadaveric in a place is increasing, the live is decreasing? That's the one thing. And the third will be, which brings to point that majority of our patients will be having a marginal donor, the expanded criteria donor, donors with sepsis. And that brings us to the challenging point that we have to relook at our intensive care units. If our ICUs are meant to treat patients, ICUs are not meant to retrieve organs. ICUs are not the organ hatcheries. Until and unless we do not set our ICUs right, that each and every patient gets the desired treatment, then only this program will start running literally in a true sense. And then the two other points, everywhere it is date registered, and then the number of transplant. It should be the date of registration or the need based. I mean, and what should be the need? And lastly, a majority of the new second transplants which are getting registered, initially live donor, now coming with the cadaveric or in the sensitized recipients, and how to tackle that. So I'll be just touching on these good and not so good points. Well, this is our current around more than 6,000 patients who have been listed across the different blood groups, and depending on the B and O being the most common, AB being the least, and that's what the general population is, and the same holds true as far as the disease donor transplantation is concerned, the number which is registered. Now, if we look at after a gap of 5 years, suddenly 2023 onward, in this, the number for registration has increased like anything. Now, why this number has gone up? So that was the one question which was this thing. And this has resulted in the waiting period from 3 years to 5 years, and non-sensitized and insensitized up to 7 years. Now that becomes the waiting period for the individual if we go just by the date of the registration. So now, why this number which is increasing? One, a lot of publicity, a lot of media hype. It is there that this is a deceased donor center or some deceased donor transplantation are being done. So patients come and get registered. And the second is this sensitized and the graft failure, the first live and the second graft. That's causing this increased number. And the third one, which was there when we analyze our data in authorization committee, when where the swab donation was, that despite having a living related donor, it was the spouse who were getting swapped. And the same is holding true in the cadaveric also. That 20% have a live related donor, but somehow, since the option of a deceased donor is available for registration, so let's get it registered. And no longer that live is explored any further, and that ends there. That 20% figure is coming up, and believe me, this is the real reason that because we also do not insist too much for that. Ultimately, it is patient's right, whatever the patient wants, whether it's a live or a deceased donor, and you cannot say no. You have to register. That's why the number is just piling up. Uh, and that is the grim reality. The numbers which have been registered vis-a-vis the number which have been transplanted, these small bars all across in the last 10 years, as you can see, the average is 10%. That's it. That's the average. In particular year, the peak may be 15%, 17%. It will drop down, but the average is not more than 10%. And this is once your program is active, the so-called a very active program. And that's why I say, if you are keep on registering this much and delivering only this much, then you have to see what is wrong, what is happening. And since last year, I think it was a huge discussion right in this auditorium, because SGPGI was going on with the full-fledged deceased donor program. And this I was talking was that are live and deceased donor complementary to each other, or it is just like a cricket run rate? The moment live transplants go up, the cadaveric transplants go down. Both of them are not following the graph upwards. Either if the cadaveric goes up, the live goes down. If the live goes up, the cadaveric goes down. And what is the reason behind that? That we need to think and find out. That is it the resources are limited, the operation theaters are limited, our ICUs are limited, our staff is limited, or our will is limited. Maybe the moment we get a good number of cadaveric transplantation, you get a lot of good publicity and you feel very happy, and you are not too much bothered about the live transplantation at that time. And what happens who do not get this thing? Now, this is the figure down below who got transplanted, who were registered somewhere. Whether they got it transplanted with us or outside, it doesn't matter, but it remains around 10%. And this is the group who still have hope, around 25%, who are still on dialysis and are getting transplanted. And this is the number who are no more, who are lost to follow up, assumed to be not more. And this is a huge number. 60% who are not there, who got registered initially. Now, that's the point where ultimately our program has to focus, not at institution level or a departmental level, but at the national level. And that's quite a scary and grim figure that what is going on. Okay, so now I'll come to a little bit towards the positive point after telling you a lot of negative points. That is sensitized patients, like criteria of a sensitized patient always is different. That whenever there's a PR is more than 20% with the MFI of 5,000, initially we used to try desensitization, not successful, so labeled as a sensitized patient to that patient. Now that group is growing, and the number of the reasons, whether it's a blood transfusion, whether it's a second transplant, it's a pregnancy, that's a standard this thing. And if we look at our figure, when we started doing donor specific antibodies for each and every patient, like we can see that 34% were sensitized recipient. Of these group of 124, majority were the second transplant. That is, who already had a graft loss, 76%. And these were the group which were the sensitized recipients. Now, in earlier on, our policy was to do a standard cross match whenever the patient used to come. And there was a problem whenever we are dealing with a sensitized recipient. And these are the three standard ways we can handle it. Kidney pair donation is a very common thing with us. Desensitization is no longer at our center, is being practiced very frequently, occasionally, and then hope for the deceased donor transplantation. And then comes the role of the cross match, the virtual cross match, when you know the HLA of the donor and you already have in your profile the antibody single antigen bead assay, where all antibodies you have, so you can know whether this is a suitable recipient or this donor is suitable for this thing or not. Now, in the virtual cross match, obviously you need to know the HLA of the donor at that time. So that's the only requisite which is required across all A, B, C, D, R, D, P, D, Q. And also in the recipient, the single antigen bead assay has already been done, and we already have the antibodies against that. So at that time, it becomes a relative easier to know about the virtual cross match. And obviously this is our report, because in general the time taken or appointment, it takes more time, because the cost of a single antigen bead assay, if I will say on a subsidized rate in a private setup, 2 PGI patient is around 25,000 rupees in Chandigarh alone. Outside it is much more, but within PGI it is 15,000, and poor free is of course zero. There is no cost. Obviously, the waiting list is huge to get the single antigen bead assay. And normal cross match, which we used to do earlier, had a lot of pitfalls in the deceased donor transplantation. Reason being, the quality of the lymphocytes at that time was not good, and we're getting either a false negative or a false positive cross match. Even tried having a lymph from the lymph node, from the spleen, the lymphocytes, but overall the quality, and the top of it, if the patient has sepsis, which majority of the patient in ICU have, and then it becomes a problem of this thing. And that's one of the references to substantiate this thing, whether you take the lymphocytes from the peripheral blood or a lymph node or from the spleen. Ultimately, the HLA expression, you are not able to know about that. And this was our journey initially. I mean, from CDC, when we shifted to the virtual cross match in 2022 only, initially every time we used to call the patients, we didn't have the record with us in the software, and then we'll check the HLA of the donor, and then we'll decide whether the cross match is positive or not. Now, subsequently, we already have a record of single antigen bead assay. HLA of the donor is done, and we already know if the virtual cross match is positive, so we do not call them at all, and we go down the list and start calling patients for this thing. So no CDC is done at all now for last 2 years. It's only a virtual cross match which is done. Initially, it was scary doing this thing without a CDC, because you are like raised with certain values, quote unquote, and CDC is one such value, that without CDC, that means the transplant cannot be done. So that was the result. I think earlier on, 16% patients we were able to transplant who were sensitized. But after virtual cross match, it was being done, it was around 35% that we were able to transplant, which otherwise were just waiting and waiting on dialysis. And the second point, which I was saying, everywhere, which I have seen in the Tamil Nadu, Maharashtra, the date of registration. Now, that is the one which is displayed everywhere, and that decides what should be the criteria for the transplantation. Whether it's the children, they should be given priority. Whether it's a second transplant, the sensitized patient who will get a rare chance to find a suitable donor, and sometimes a living donor, if his or his relative getting complication, should that person be given some chance. Although in the country, one policy, one country, everything is there, but still we deviate from that, and this is our scoring system, okay, which we follow, that apart from registration, every point is given. For children, extra 20 points are given. Those who have a graft loss, they get 20 points. Sensitized recipients get 30 points. First degree relative of the deceased donor already was given, he gets 40 points. And the living donor who ultimately gets some CKD, he gets 50 points. So this is the point system which we have evolved. And a lot of complaints, we have submitted this system to the High Court also, and nobody has objected so far. Although country-wise, if you say, the only system which works is the first one, the date of registration, and nothing else. But this is how we are following, and we are getting a lot of appeals, investigations, court cases, but still we are holding on to that. That was a joint decision, duly vetted by this thing as to what will be our criteria like. And then the third point, in ICU, once you have a brain dead or brain stem death person, should each and every person is a suitable donor? The first and foremost is sepsis. I think in majority of the hospitals, especially the retrieval center, because last time this was being talked in different government hospitals where the majority of the trauma comes, with this, sepsis is always there. Now, I think without sepsis, it will not be there. And that raises the question, the better ICU quality care with us, because that will not only improve the general condition of the patient, but also the disease donor transplantation. Similarly, the donors who are more than 60, who are hypertensive, where while in ICU, their creatinine is more, more than 1.5 milligram per deciliter, whether to take them. Similarly, the pediatric donors. Now, whenever there is an infection versus non-infected, obviously outcomes are better in non-infected, though no long-term data is available. Uh, but it is always, as usual in the studies, said that as long as wait listing is concerned, it is better if you have even an infected donor. It doesn't matter. It may be better than being wait listed. But here I'll say a word of caution. It all depends upon the relative. I'll come to this point because many of times patients are taken up, but they end up with some other surgery with a, let's say, gangrene, gut gangrene, because they already had a septicemia that has to be uh, tackled. Mm, sorry. Okay, and this will be the substantial chunk where whether to take which kidneys, which I said more than 60 or already having underlying kidney disease, whether to put both kidneys if the kidney is compromised, so that this expanded criteria is there. Uh, and that's the definition which we have used, although we have used even those donors with the creatinine 3 and even more than 3 milligram per deciliter with fingers totally crossed whether this is going to work. But now here I'll like to say one thing which may sound a little offensive to somebody, that it's a very easy in a government setup, like in our setup, where patient population is just a captive patient population. Whatever you offer them, they accept it. So it's very easy. But once, even in SGPG or outside, you have to be very, very careful whatever you are telling them. That they're for the same quantity of immunosuppression, whether that kidney will function or not function, B, how long will it function? Because they will become sensitized for the next transplant. Now, that is the level of counseling which majority of us have to do actually. Being in a government setup, you get away with this because you do not deal with the fussy patients. And I always say within the department also that we need to have fussy patients within the department, because that only the real challenge comes to us. Similarly, the pediatric donor, even the irrespective of the age, it can be there. And even in fact, if you had listened to Prime Minister's Man Ki Baat, he referred to one of the patients, less than a month old, that was from our center. That's the one part of the story. The second, I will not say. Okay. And whether this is the thing policy which is there, that when there is a less than 10 kg, it's an en bloc kidney transplant, both kidneys getting transplanted at one. More than 10, okay, it can be done in this thing. As far as sepsis is concerned, now this needs to be explained to the patient's attendant uh, very, very properly. And uh, the deceased donor transplantation, I mean, just now the last lecture was about the digital health. And since Dr. Jha mentioned that, I will not be mentioning many places. So, so this is our own department's database, which we keep our deceased donor transplant record, because it's very taxing. Actually, the deceased donor transplantation, having 6,000 patients database, it's very, very taxing, and coming out with this thing. And so you need to have all side of a management with the drop down menus, so that the things can be done very quickly, and you can come for this thing. And these are the two things which we had added off late only. And was the integration of SMS, that the moment the patient gets registered, the whenever every 3 months they have to come to tell us that they are keen, interested. So that automatically that message goes to them after every 3 months. And if they do not come after 6 months, then the message goes that no, your name will be stuck off. So you better let us know whether you are coming or no. And this has not been done. That the DSA report from our lab gets integrated with this software, so that it's easy rather than physically looking at each and every antibody. So it can be done. Now this is has not been done, but I feel this should also be done, that the report from the lab should go straight to the database, and accordingly then it will be the true virtual cross match with minimal efforts. And okay, so behind the wheel, I kept this title like that only. I think for a deceased donor transplantation, we have to get out of this mindset. And this is the line which Dr. Raja had used. I loved it. Success is mine and failure is yours. And and this is the teamwork where without that it cannot be done. I mean, you cannot say that the nephrology claims or a urologist claims success, and when the success is not happening, it is that the brainstem declaration is not being done by the neurosurgeon or neurologist. The failure goes to the administration, the success goes to the department. No, this cannot be done. I mean, that should not be there. And the second is equally important, the ICU care. I think it has to be improved all across the country. Otherwise, having infected donors everywhere, there's no point. For example, if you have in the whole UP different retrieval center, the transplant may be done here. You may be getting from only government hospitals because majority of the trauma will be going there only. Unless their ICUs are good, they are providing a good care, you will be getting only infected donors, and then there will be a problem. And the last is an interesting point, I think, which of late only we have observed. Earlier on, whenever we had a deceased donor, we used to call just 6 prospective recipients. All 6 will come immediately running. Now, if we document each and everything, the minutes where that we called, so and so picked up the phone or said, no, I am not willing to come. Now we go down to 40 or 50. Some are medical reasons, they are not fit, but other is the real thing, that empowerment. The patient simply says, why should I spend that much of money on immunosuppression for a compromised kidney when I am getting my dialysis free and close to my home? Now, that is the empowerment which of late I have observed, which is there, that patients just refuse to come for a deceased donor, or sometimes they say, maybe we'll think about after a couple of months, my wife is not around, so I need some help. And these are the earlier or unheard of answers. And that's a really encouraging that at least in state of Himachal, it's free dialysis almost all across, and it's a better quality of dialysis. Patients are surviving for more than 7 years as a routine, so they are willing to wait. That's why the number of deceased donor registration is going up. And of course, with the virtual cross match, the unnecessary visits are no longer necessary. They come only when it is there. So with that, I think still I'll say uh, 5 years ago, this used to be my line in my department always, that good is the worst enemy of the best. If you get satisfied with the good, best will never. A particular position in a government setup, this thing, the best is the worst enemy of the good. So you have to start. At the beginning has to be made. Ultimately, it becomes best. But if you just hope for the best, that your ICUs will become best, no, they will not become best in the beginning. So you have to start, and it's good that this is the learning of whatever deceased donor transplant program is going on, that it should be a team one. And if uh, the team is there, this is Professor Kher batting during the conference picnics with the tradition he took from PGI Chandigarh and followed it up here. I don't know, Dr. Narayan Prasad, whether it is being followed up. Unlikely. The conferences have become picnics. So I think they should be little break from there. And that was when Professor B.K. Sharma had come 1990, I think, as a visiting professor to the department. And it was a wonderful, at that time, interacting with him, and especially one room which I think will be of one of your consultants, and his name with the white coat and red embroidered thing, and he loved that thing only. The white coat should always be there. So that's the memories, good memories of the department, of the place, which are there apart from whatever things we have learned. So with that, I think I'll conclude, and thank you so much for listening to this.